Hello everyone, I am Dr. Gyan Chandra Paudel, MD Radiologist. Today I am going to present a case of a 52-year female who presented with progressive shortness of breath with no history of fever, occupational exposure, no any chronic drug intake or past history of pulmonary tuberculosis for which HRCT chest was suggested. Before going to CT scan, let's discuss about certain important terms that are required to be known while describing any HRCT finding in lung. These are reticulation. These are the collection of small reticular linear opacities which resembles like a net. This axial image shows multiple linear opacities. As we can appreciate, multiple linear opacities giving a net-like appearance. These are the reticulation. All these are the reticulation in axial and sagittal image. We can appreciate all these reticulation giving a net-like appearance. And the next term that we need to know is honeycombing. Honeycombing is actually well-defined adjacent cystic structures that typically clustered in the subpleural region, and it should always be used if there is a sign of fibrosis. So this is these are multiple cystic spaces stacked upon each other in subpleural region, giving typical honeycombing appearance. These are the cystic spaces giving honeycombing appearance. Almost we can appreciate 3 rows of cystic spaces stacked upon each other with honeycombing. In this image we can, I think there are one layer of cyst giving honeycombing appearance with associated surrounding reticulation or fibrosis, and this image shows multiple cystic spaces with honeycombing in subpleural region. This is yet another honeycombing. After that, we have to know about ground glass opacities, which is increased area of attenuation with preserved bronchovascular margin. This image shows increased area of attenuation with preserved vascular marking. This is known as, this hazy area of opacity is known as ground glass opacity. We can clearly visualize the vessel passing through this haziness of lung, and in this image we can see haziness of lung, which is ground glass opacity. And this next image we can see ground glass opacities, very severe form of ground glass opacity with associated fibrosis of the surrounding lung as indicated by traction bronchiectasis. So another entity is traction bronchiectasis, which is lack of tapering of the bronchi and which is visible within 1 centimeter of the pleural space, but that should always be associated with fibrosis to say it is a traction bronchiectasis. So this image shows multiple linear dilated bronchi with surrounding areas of fibrosis. This white structure is fibrotic changes leading to traction bronchiectasis. These are the dilated bronchi. This is dilated bronchi with surrounding white area of lung fibrosis. And the next image shows fibrosis with traction bronchiectasis, associated traction bronchiectasis. These are the traction bronchiectasis with surrounding fibrosis. This image collectively shows all these terms in one slide, like reticular opacities, these linear structures, net-like appearance of interstitial thickening is known as reticulation. This is honeycombing, which is the cluster cystic ear spaces with well-defined walls on the order of 3 to 10 mm in subpleural space, honeycombing. And this is ground glass opacity, increased areas of attenuation with preserved bronchovascular marking. This is ground glass opacity. This haziness of lung is due to ground glass opacity, and traction bronchiectasis, which is bronchial dilatation caused by surrounding pulmonary fibrosis. So this is traction bronchiectasis with severe surrounding pulmonary fibrosis. Now you are ready to dive into the CT scan. This is the axial HRCT chest, which shows multiple reticulation in bilateral lung field, predominantly in bilateral lower lobes. These are the reticulation, a linear lacy appearance of thickened interstitium. This is reticulation. There are also multiple cystic spaces stacked upon each other in peripheral and subpleural region, giving a honeycombing appearance. So this is the honeycombing. These are the honeycombing in bilateral lower lobes, predominantly in bilateral lower lobes, honeycombing. So these are bilateral upper lobes. There is reticulation, but compared to the lower lobe, there is a minimal area of reticulation and minimal area of honeycombing. These are the honeycombing in bilateral upper lobe. These are the reticulation. And other findings are traction bronchiectasis. This is the traction bronchiectasis secondary to fibrosis of the lung. These are the dilated bronchi, which are reaching almost up to the periphery. This is the dilated bronchi. This is the linear structure. This is the dilated bronchi, which is also known as traction bronchiectasis. The bronchi is almost reaching up to the pleural surface of lung. So this is traction bronchiectasis, and we can also appreciate minimal area of ground glass opacities. These are the hazy areas of ground glass opacities in bilateral lung field, predominantly in bilateral lower lobes. Comparing with bilateral upper lobes, so this is the axial image, this is a coronal image, and the sagittal image showing traction bronchiectasis, honeycombing, multiple reticulation, and few areas of ground glass opacities with apicobasal gradient, because lung bases are involved more than apices. Apical region is less involved than lung bases. So this is a coronal image where we can appreciate traction bronchiectasis with surrounding area of fibrosis, severe area of lung fibrosis in bilateral lower lobe. Honeycombing, predominantly peripheral in location, subpleural in subpleural region. So this is a classic case of usual interstitial pneumonia, UIP, a part of interstitial lung disease. So let's discuss about interstitial lung disease. Interstitial lung disease is a broad group of lung disorders that primarily affect the interstitium, characterized by diffuse cellular infiltrates in a periacinar location, which is the functional unit of lung for gaseous exchange. It may range from occasional self-limiting inflammatory processes to severe debilitating fibrosis of the lungs. This table shows classification of interstitial lung disease with any non-cause. When it is idiopathic, it can be due to granulomatous disease or any unique entities like pulmonary alveolar proteinosis or eosinophilic granulomas. This slide mainly shows common cause causing interstitial lung disease. When there is like occupational exposure like asbestosis, silicosis and hypersensitive pneumonitis, and when the patient is in radiation and if there is history of intake of methotrexate, amiodarone or nitrofurantoin drug intake or any chemotherapeutic drug intake. And it can also be due to any granulomatous disease with vasculitis like granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and some granulomatous disease like sarcoidosis, and connective tissue disease like rheumatoid arthritis, scleroderma, polymyositis and dermatomyositis. So these are the common non-cause that leads to interstitial lung disease. But today we will be discussing on idiopathic interstitial pneumonia, which is diffuse interstitial lung disease of unknown cause, which is characterized by cellular infiltration of the interstitial compartment of the lung with varying degrees of inflammation and fibrosis. They are classified, idiopathic interstitial pneumonias are classified into 7 subtypes. Usual interstitial pneumonia, UIP, or idiopathic pulmonary fibrosis, IPF, idiopathic non-specific interstitial pneumonias, NSIP, cryptogenic organizing pneumonia, respiratory bronchiolitis associated interstitial lung disease, RBILD, DIP, LIP and AIP. We will mainly be discussing about UIP and NSIP pattern, as other are less common in our clinical setting. Now let's talk about our main topic, which is usual interstitial pneumonia, UIP. This slide shows diagnostic HRCT criteria for UIP, which is classified into 4 types according to the distribution and features, which is UIP pattern, probable UIP pattern, indeterminate for UIP pattern and alternative diagnosis. UIP pattern, which means a definite UIP, is when there is basilar and subpleural distribution of the disease with associated honeycombing, reticulation and traction bronchiectasis. We will say probable UIP pattern when there are all these UIP patterns with no honeycombing in this condition. And let's talk alternative diagnosis first, where there is involvement of upper and middle lung with peribronchovascular or perilymphatic distribution, which is which means there is central involvement of the lung, unlike UIP, which is peripheral. And there are other CT features like CIS, MAT, mosaic attenuation, predominant ground glass opacity, profuse micronodules and other nodules, consolidation, then we always think of alternative diagnosis, then UIP. Like other associated finding like pleural plaques, dilated esophagus, distal clavicular erosion and extensive lymph node enlargement, we always consider alternative diagnosis, then UIP. And in indeterminate for UIP pattern, the distribution is basilar and subpleural, but there is subtle reticulation with mild ground glass opacity. It's like early UIP pattern. And when there is no any etiology known for associated fibrosis of the lung, then we say it is indeterminate for UIP pattern. So this image, axial image, gives typical finding of UIP with multiple honeycombing, traction bronchiectasis, multiple linear reticulation, honeycombing, reticulation and traction bronchiectasis. Another image shows traction bronchiectasis, honeycombing, subpleural based honeycombing and multiple reticulations. Another image which shows subpleural location of honeycombing, that is peripheral in location, with reticulation, multiple reticulation and honeycombing. So UIP can be either idiopathic or can be associated with connective tissue disorders. When it is associated with connective tissue disease, then there are typical signs that says that it is secondary to connective tissue disease. These signs are exuberant honeycombing, anterior upper lobe sign and straight edge sign. This sign says that the UIP is secondary to connective tissue disorder. Other extrapulmonary signs that says that UIP is secondary to connective tissue are pleural or pericardial thickening, when there is esophageal dilatation, when there is pulmonary arterial dilatation, soft tissue calcification or shoulder or AC joint erosive arthritis, then we can say that it is secondary to connective tissue disease. In this image, the axial image shows exuberant honeycombing in bilateral lower lobes, very severe form of fibrosis with few areas of normal lung. Almost more than 70% of the lung has been involved to say that it is exuberant honeycombing. And this coronal image shows severe fibrosis in bilateral lower lobes with normal lung in upper lobe, which is demarcated by an imaginary line. So this is an imaginary line which divides normal lung from severely fibrotic lower lung. This is known as straight edge sign. And this is anterior upper lobe sign, which shows honeycombing, reticulation and traction bronchiectasis in upper lobe, anterior aspect of upper lobe. This sagittal image shows anterior upper lobe sign, as that is fibrotic changes is seen in anterior upper lobe. Lastly, let's talk about NSIP, non-specific interstitial pneumonia, which is the second most common morphologic and pathologic pattern of interstitial lung after UIP, which is most commonly associated with connective tissue disease. NSIP is mainly divided into two types: fibrotic NSIP, which is very common, and cellular NSIP, which is less common. So, the radiological features of NSIP are ground glass opacities. That is the main dominant feature in NSIP, which is mostly symmetrical or diffusely distributed in all zones, or may show a basal predominance. When there is immediate subpleural sparing, then we are relatively sure that it is secondary to NSIP. One of the very important term, which is immediate subpleural sparing, which says that it is NSIP. NSIP is mostly bilateral and is symmetrical, and it is mostly peripheral in distribution. Other associated finding that is seen in NSIP are the reticular opacities and traction bronchiectasis, which is commonly seen in fibrotic type of NSIP. In advanced case of NSIP, there can be traction bronchiectasis, consolidation, and microcystic honeycombing. So, this is axial image which shows diffuse ground glass opacities in bilateral lower lobes with traction bronchiectasis. These are the traction bronchiectasis with severe ground glass opacities in bilateral lower lobes with associated reticulation in bilateral lower lobes. This is the same patient with showing ground glass opacities in bilateral upper lobe with reticulation. This is the coronal image showing traction bronchiectasis, ground glass opacities almost diffusely involving lung, more severely in bilateral lower lobes. And this is this is the sagittal image of the same patient showing traction bronchiectasis, diffuse ground glass opacities, and reticulation. This is another case of a patient with NSIP showing diffuse ground glass opacities with areas of traction bronchiectasis, multiple reticulation, reticular opacities, more severely and involving bilateral lower lobe. This slide shows differentiating features between UIP and NSIP. In UIP, there is always or mostly apico-basal gradient is present, whereas in NSIP that is not necessarily important. UIP is always heterogeneous, whereas NSIP is mostly homogeneous. Ground glass opacities are seen in NSIP, whereas ground glass opacity is very minimally seen in UIP. Honeycombing is seen in UIP, whereas in NSIP it's very minimal. Micronodules are seen in NSIP, and traction bronchiectasis is more common in UIP.